Okay, I think we're going to go ahead and get started, if that's okay with you, Steve. So welcome everyone to the Essential Substance Abuse Skills webinar series. My name is Ella Driscoll, and today Steve Stein will be presenting Treatment Knowledge Part 2. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are part of the ATTC network, which operates out of the University of Iowa in Iowa City. In the next couple of days, we will send out a follow-up email to everyone who attended, which includes a link to the recording, the handouts of the slides, and a CEU request form. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEUs. We are currently waiving any fees for CEUs during quarantine, and when we send out our follow-up email, you can simply reply to the email that we provide and request a certificate for your attendance. Immediately following today's webinar, you'll be redirected to our GPRA evaluation. This is just a survey we give out, which just takes a few minutes to complete and asks about your satisfaction with the event. This feedback is critical to our future work, and we value your opinion and would greatly appreciate your time and sharing your thoughts with us. You will be muted for the duration of the webinar. Please use the chat feature to share your questions and comments, and we will address them as well as we can. And we will also save any that we aren't able to cover today for future sessions. So many of you may be familiar with our speaker today, but Steve has been certified as an alcohol and drug counselor in Iowa since 1997, working with behavioral health for over 23 years. He's been in recovery for over 32 years and has committed his life to helping others. Thank you so much, Steve, for being here and giving us your insight on this awesome topic.
Well, that was a very nice intro. Thank you very much, Ella. Yeah, great to be here with all of you again. I'm going to now see if I can pull up the slide deck. What I'm hoping to do is pick up where we left off last time. I'm going to backtrack just a little bit and want to review the co-occurring disorders, because I know at the end we kind of ran out of time and had to rush through some of that. And then we're going to spend the majority of the remainder of the discussion today reviewing medicated-assisted treatment or medicated-assisted therapy. So I'm really glad to have you all here. My name is, as Ella said, my name is Steve Steiny. I am broadcasting to you live from the University of Iowa campus. It's a little subdued around here. We are in full protocol because of the pandemic going on, so there's limited access to live classes, and most of the classes are being done online. So very, very quiet here, but that's a perfect opportunity for me to spend some time with you this afternoon. So let's get started, and I'm hoping that we will have a little time at the end to maybe field some questions or have a dialogue. So I'm going to go ahead and see if I can get my screen share going. Hopefully I'll pull up the right screen so that you guys don't see all my secret documents. Let's see. Okay. You guys see that okay? Is that should say behavioral health integrated care? Is that the right
Looks great,
plot?
Steve.
Yeah? Fantastic. Okay, and I know later on Ella will be putting the link to our GPRA survey in the chat box. And again, it's just great to see some familiar names and faces. Well, I'm not seeing faces this time, but certainly some familiar names in the attendees area. So let's go ahead and get started. I want to just take a couple of minutes before we go just to sort of clear our minds a little bit, maybe close down some other things you're working on, silence your phone, and let's just clear our heads for just a moment before we get started. Okay. I needed that reset, so I hope that it was helpful for all of you as well. Let's go ahead, and we're gonna pick up where we left off. I'm gonna backtrack just a little bit. I want to talk a little bit about behavioral health and integrated care, and recover some of the co-occurring disorder slides that we kind of skimmed through pretty quickly last time. So can you guys still see that screen okay? Okay.
Looks great, Steve.
Okay, wonderful. Thank you. I can pull up the chat box. It just involves me pulling it down from the top of the screen. So I think, oh, there, I got it. So thank you. So let's go ahead and take a look at, we're going to look at behavioral health as an integrated sort of system. And you can think of kind of ROSC, you can think of this being an interconnected or interrelated system of care. And this diagram or this visual sort of helps me see it in that context. And I think one of the things I want to remind us of as we talk today, and I share some information with all of you, we're talking about treatment planning and some of the considerations that we would take into account as we work with patients in our respective fields, whether it be treatment, substance abuse treatment center, substance use disorder treatment center, whether it be a mental health facility or a combination thereof, and whatever level of care. It could be an entry-level outpatient clinic, or it could be an acute care medically monitored detox unit. This applies. This statement applies, and it's something that in my own clinical experience, working with patients for many years, this was something that was very important for me to remember. A patient's substance use is not the problem, but rather a sign or symptom of another underlying issue that's driving that substance use. That's not to say that their substance use is not causing them problems, but it's not the problem. It's a symptom or an indicator that they're struggling with something else underneath that. Let's keep that in mind as we continue to have a discussion today. So let's look at, I want to look at, again, to review some of the slides that we talked about last time. And I really want to put the question out there, and I'm going to use the term co-occurring disorder. There's other terms that can be used, dual diagnosis, or there's other terms that can be used, but we're going to use the term co-occurring, or you may hear the term comorbid, but we're going to talk about co-occurring disorders. What does this mean? Well, in the medical field, comorbidity is either the presence of one or more disorders or diseases in addition to the primary disease or disorder. So in other words, there may be an identified substance use disorder as the primary, and then there may be underlying or comorbid mental health disorders that are also identified in the patient's history. The term dual diagnosis is also used to describe this comorbid condition of a person considered to be experiencing problems connected to their mental health and their substance use disorder. That's just something to keep in mind as we go through this. And I know many of you listening in currently are working directly with patients that are experiencing both substance use disorders and a mental health disorder, either formally diagnosed or informally diagnosed. So again, asking you all to consider, what are co-occurring disorders? Well, simply put, it's the presence of at least two disorders one being a substance use disorder, and then the other being a mental health disorder described or identified in DSM-5. And I just listed a few of the common co-occurring mental health disorders that we see with our substance use disorder patient population, and those are listed there. Just to move forward on this idea or notion that we build on this idea of a co-occurring disorder, we would look for this repeated cycle through treatment. This repeated cycling through treatment settings, emergency departments, detoxification centers, jails, or psychiatric units, jails, other institutions. Co-occurring disorder patients may be more likely to reoffend or receive sanctions when they're not taking their medication, or they're not in treatment, or they're experiencing mental health symptoms and or actively using substances. It's important to note too that even small amounts of a substance, including alcohol, may trigger the reoccurrence of a mental health symptom. One of the most classic examples that I learned early on was a patient has an underlying co-occurring diagnosis of depression, and then they are using alcohol, which is a depressant. So even though we know alcohol is biphasic and it initially sort of picks you up, makes you feel good initially, ultimately it is a CNS depressant and just adds to and often makes worse the underlying condition of depression. So I want to look and note too that it's important for those of us that are using ASAM criteria, and ASAM criteria, as some of you may know, is a set of standardized dimensions and risk ratings associated with each dimension that really affords the clinician opportunities to identify, treatment plan, and monitor the progress for patients with both substance use disorders and mental health disorders. ASAM dimensions can be used as this supplementary assessment tool for co-occurring disorders. It has a separate section that is equivalent to the substance use disorders section when assigning risk ratings in each of the respective dimensions. Now, those of you that are not familiar with the ASAM criteria, I would encourage you to explore that. And if your agency is required to use these criterion when assessing patients, making referrals, and assigning levels of care, then it's important that you would know what the ASAM dimensions and risk ratings are. ASAM, as we know, stands for the American Society for Addiction Medicine, and that criterion and dimensions have been around for several decades and have evolved over the years. But that's a different conversation. Again, when assessing co-occurring disorders using the ASAM dimensions, and those risk ratings can be a valuable tool. Assessing the significance of the substance use disorders. So very important when we're looking at the co-occurring mental health disorder that we also have an accurate picture of what's going on with the substance use disorder. So obtaining a accurate long-term history of both the mental health and substance use symptom onset, and we're going to visit this idea of age of onset in a later slide, and to really take a look at whether the mental health symptoms occur only in the context of substance use. In other words, are they substance-induced, or are they stand alone and exist even when the patient is not actively using substances? And then to determine whether the substance or whether sustained abstinence leads to rapid and full remission of the mental health symptom would be an indicator that we're really talking about a substance-induced mental health disorder rather than something that's organic or pre-existing. Some of the characteristics I think that are noteworthy, and again, we're kind of reviewing these because I think I zipped through them last time, but some of the characteristics I want you to note, and I know many of you are familiar with this, and it may be a overall review for many of you. So, but some of the characteristics for co-occurring disorders: more rapid progression from initial substance use to higher levels of severity, difficulty maintaining any medication compliance, difficulty in gaining access to or initiating treatment or completing treatment, greater rates of hospitalization, more frequent self-harm behaviors, difficulty social functioning, and a shorter time in remission of symptoms. In other words, symptoms may succeed and improve, but oftentimes in co-occurring disorder patients, we see those remission states are short-lived and not sustained. Other characteristics worth noting: there may be some difficulty comprehending or recalling important information. So there may be some temporal issues with timeline and some executive function compromise with a co-occurring patient. They may not recognize the consequences of their behavior, or there may be a disconnect there related to the co-occurring disorder. There may be issues involving poor judgment or lack of organization, limited attention span, or and they may also ultimately respond better to patient-centered approaches. And I would add that there may be also times where foregoing group involvement may be more beneficial to the patient and working with them individually rather than in an individual and group setting. But again, those can vary depending on the patient's history and the severity and or combination of their co-occurring disorders. It's worth noting co-occurring conditions in adolescence. I think this is important, and I tried to find the source for this, but 90% of youth with a lifetime co-occurring disorder had one mental health disorder prior to the onset of substance use, and I'm looking for where that was sourced, but I think that's a striking number. That's 9 out of 10, and then this is also worth noting. The median age of onset for a mental health disorder with youth population is 11, and the onset for substance use disorder is between 16 and 21. Now, I would say that, age of onset for me in my own experience in making substance use disorder assessments, the comprehensive assessment, I often focused on age of onset as and it usually would serve me as a pretty accurate predictor for acuity and the duration of the substance use disorder later in the adult lifespan of the patient. So in other words, if patient X reports starting to smoke marijuana with their older brother at age 8 or 9, the likelihood that they are going to have more difficulty over time and into their early adult lifespan is much increased based on the age of onset. Whereas the research and evidence that is out there now says that the longer you can delay the use of substances in a young person, the less likely they are to go on and have difficulties later on in life. So there's quite a bit of research out there about age of onset and how it serves as a predictor and can also be a way to gauge whether the person will have difficulties later on. Again, this is a reminder. We have to see the person's substance use. Well, we don't have to, but I'm really encouraging you to view the patient's substance use as a symptom or an indicator that there's something else going on. And I want you to think on a biopsychosocial level when you ask yourself this. There could be a number of things underneath that use that are driving it. Some of the biggest ones, those of you that have heard me speak before know that 8 out of 10 of the patients that I worked with would report some sort of trauma, either past or recent past or recent, some sort of trauma-related event. Also would report some sort of grief or loss issue, either resolved or unresolved, that as one of those underlying components driving their substance use. So really important for me, training new clinicians coming into the field, to stress this, because if we simply focus on the substance use as the problem and remove that, then you essentially have someone who is without a coping mechanism or without support to address those underlying issues. So providing alternative means to address those issues in a healthy, safe, supported way is really, in my opinion, the primary goal of the clinician working in the behavioral health field, particularly with substance use disorders. So let's jump into, and I really wish we had time to I could hear from you all if we were in a live event. I really would like to hear some of your thoughts about this, because some of you may have different views on this notion, and I respect that. This is simply my own experience in working in the field and working with many, many patients that meet criterion for a substance use disorder and or a mental health disorder. So let's take a look now. I want to spend a little time looking at some pharmacological components of medicated assisted therapy. And we know this has been a hot button issue the last 5 or 6 years, but I think it's also important to note that MAT has been around for decades. It goes back many, many, many years, and things have a way of recycling and reinventing themselves. And I think with the onset of the opioid epidemic, as it unfolded in response to the access and the promotion of a lot of the synthetic opioids by the big pharmacy business, we saw a real spike and continue to see a spike in opioid-related deaths, overdoses, and treatment admissions. So I want to talk a little bit about medicated assisted therapy, or you might hear it also referred to as medicated assisted treatment. So it's important, I think, to look at a couple of different components to this. When we think about pharmacotherapy, we think about a couple of different things. We think about detox and withdrawal management. We think about addressing cravings or urges. We think about replacement. We think about this aversion or this aversive notion of pharmacological intervention. We think about this notion of an antagonist, and then this sort of combining of an agonist and antagonist when we're addressing particularly opioid use disorders. So think of when we think about the aversive nature, think about this relating to or denoting. Oftentimes you hear of aversion therapy. So this would be a type of behavior therapy designed to assist the patient in giving up an undesirable habit by causing them to associate it with an unpleasant effect. And just for simple clarification terms, an antagonist is a substance that interferes with or inhibits the physiological action of another. And an agonist is a substance which initiates a physiological response when combined with receptors. So it sort of mimics or tricks the receptor into thinking that the drug is present to avoid withdrawal. And this will make a little bit more sense as we continue to have this discussion. So when we think about medicated assisted therapy, let's think about MAT is the use of FDA-approved medications in combination with counseling and behavioral therapies to provide a whole patient approach, or this holistic approach, to the treatment of substance use disorders. And this, I think, this treatment approach has taken on new meaning, considering, as I said, the recent and increasing sense of urgency surrounding the opioid crisis that has really gripped portions of the nation from coast to coast. That usually involves a replacement medication like methadone or buprenorphine or naltrexone to assist the patient in reduction of cravings, and then to prevent or replaces and helps stabilize often difficult and or disruptive withdrawal symptoms associated with opioid use disorders. When we talk about opioid use disorders, I really want you to think of them first and foremost as a brain disorder. And until that brain is treated, progressing through the continuum of treatment engagement is almost impossible. So it's something that's very, very important when we talk about this continuum or looking at a patient's treatment engagement from A to B to C to D, if we look at it in that linear way. And I think it's important, too, to understand that when we talk about medicated assisted treatment, we're not just talking about medications for treating opioid use disorders. Alcohol use disorders have been treated for many, many years using different forms and medications or pharmacological interventions to supplement the treatment engagement. So using naltrexone or Vivitrol or Antabuse or Campril are all ways that a patient can be assisted in reducing cravings and reducing the propensity for relapse or return to active use following completion of detox. Now, when we talk about withdrawal from alcohol and detox too, we're not talking about the recalibration of the patient's physical dependence, but we're really talking more about addressing their alcohol use disorder neurochemically and assisting them in that way so that they can move past some of the cravings and difficulty in early recovery to move into a more stable or maintenance portion of their recovery state. So again, just talking more about the MAT notion, the medicated assisted therapies. When we put this in the context of opioid use disorders, many of us, at least for me, I often default to this idea of methadone as being the primary means for treating an opioid use disorder patient through this the liquid application. So methadone is very popular. Naltrexone is another. I wouldn't say more modern, but it certainly is something that is being used more now to help reduce cravings Vivitrol is the real advantage to this is that it comes in an injectable form. It is still cost prohibitive. However, not having to take something daily orally and having an injection that lasts, anywhere from 15 to 28 days is really, there's a lot of advantages to that. We look also at so naltrexone being used for opioid use disorders, Vivitrol being used, Subuclade is an injectable form of buprenorphine, Suboxone or Zubsolv again is a combination. It's an antagonist agonist, so it not only addresses cravings and urges, but it also prohibits the patient from receiving the positive effects if they were to relapse. They simply are not able to get high, basically. And the Buprenorphine also is something that is, it was new at the time. I think it's taken on a little more. It's taken on a little more of a. It's more popular now, but it's an implant that is again a time release, but it's inserted just under the skin, and it doesn't involve a daily oral or sublingual dose under the tongue. But again, there may be some cost prohibitive components to this as well. I think it's important to make this note to the clinicians out there working in the field. I think when we refer, it's really best practice to use the term opioids when referring to opioid use disorders. The term opioid covers all of the different types of opioids. So from synthetics to semi-synthetics to natural forms of the opiates. So if you use the term opioids, you cover everything, and it's something good to keep in mind as you address this with families or with colleagues or patients. So using the term opioids covers everything. And that's a great question. I see a question coming in from Clem. Yes, certainly naloxone. I did read that article about the exposure. That naloxone really is the ultimate sort of rescue drug for overdose cases. It immediately reduces or removes the effect of the opioid, and especially in cases, as Clem has noted, where there is fentanyl or carfentanil involved, which is a much more powerful form of the drug, synthesized form of the drug that has devastating effects especially for opioid use disorder patients or opioid use disorder patients who are actively using, who are not aware that their heroin dose, for example, has been laced with fentanyl, which they may be using a specific dose and be used to that, when then they use the dose that's been laced, and they're prone to overdose. So naloxone is available, and I think in a lot of larger urban areas, Clem, I think it's even available at no cost or almost pennies on the dollar for individuals to have at least 2 or 3 injection kits, or the nasal spray is also a very popular means to administer the naloxone. So yeah, definitely, that was a scary article. I remember reading that. So I hope that addresses that question. Just some basic sort of facts. Again, this is probably review for many of you, but so just some basic opioid facts. Opium-derived or synthetics, which relieve pain, they produce euphoria, and morphine-like addiction, and then relieve withdrawal from opioids. So it gets complicated when we start talking about some of the synthesized versions, and there are many, or semi-synthetic versions of opioids that are available through prescription. A lot of different medical uses. One of the things, if we think about those underlying or co-occurring disorders, one of the issues that I would also often see with patients, at least in their history, if it wasn't currently happening, was chronic pain. And this was sort of the open door to how they went down that road and began to experiment with or use opioids, maybe first as prescribed, but then later not as prescribed, and those were diverted and abused. And that oftentimes would be the gateway to their opioid use disorder issues. We know methods of use. Certainly the injected or intravenous means of administration, smoking, snorting, or taking them orally, as you would in a pill form for different prescribed medications. Withdrawal, I think, it's prolonged and very difficult, but it's important to know that it's not physically life-threatening. You may feel as though you're going to die, but you will not. Unlike a drug like alcohol, where your body can go into shock and you can pass away. That being said, the psychological and physiological effects of opioid withdrawal can indirectly be life-threatening, but there is no evidence to support that if you are not treated medically for opioid withdrawal, that you would be at risk for dying. But there are certainly a lot of other factors that play into that statement. Just a brief history. The Drug Abuse Treatment Act of 2000. Here we saw the approval of buprenorphine. Yes, say it with me, buprenorphine. It took me a while to be able to say that without getting tripped up. But 2000, there was the approval of buprenorphine by the FDA, and the treatment of opioid use disorders allowed for the expansion of traditional opioid treatment programs beyond the current structure to include treatment in outpatient offices settings. So it didn't have to just be through a designated clinic or a hospital setting. And then this afforded patients better access to treatment and reduced some of the stigma, and then just broadened the definition of treatment for this disorder based on where it was administered. We know that opioid use disorders continue to be a significant public health problem across the country, and I'm not even addressing the issue as it's playing out in tribal communities, because that's another matter that certainly would be worth discussing at some point. But in 2007, it was estimated that about 12.5 million Americans aged 12 or older used prescription pain medications for non-medical purposes. I think at one point they said there were enough synthetic opioids in prescription form to supply every man, woman, and child in the U.S. with a 30-day supply of pain medication, which is just astounding. And we now see this playing out with a lot of lawsuits being put forth and litigation underway to hold the pharmaceutical companies responsible. By 2019, full-scale efforts to systematically decrease the access to prescription opioid medications from the previous decade have created this continual surge in overdose deaths and ongoing use of heroin, fentanyl, this creating this epidemic we see cycling through our healthcare and substance use disorder treatment system today. And so you add this constriction of these medications through the prescription monitoring programs and a real shutdown of access to prescription medications, and then people would turn to illicit access, and this is where we saw the surge in overdose deaths and other complications. So a very wicked cycle that I still know is we're not over, but again, it can manifest in different ways as well. But again, just to continue this, just to give you some historical context, 1964 methadone was approved for use. 1974, the Narcotics Treatment Act limits methadone treatment to specific licensed opioid treatment programs, these OTPs. And then in 84, naltrexone was approved, but continued to be rarely used until it was reapproved or sort of reinvented to treat urges and cravings related to alcohol use. And then we've seen another sort of spike in its use to address opioid use disorders in the past decade or so. This Drug Treatment or Drug Addiction Treatment Act of 2000 expands the clinical context of medicated assisted opioid treatment. Tablet formulations of buprenorphine or Subutex and Suboxone were approved by the FDA. So we see that happening in the early 2000s. And then this is marketed heavily for the use of opioid use disorder treatment in the early 2000s. Really pushed in the early 2000s, and then enabled in 2003. Some changes were made so that these could be administered in outpatient clinics and offer the buprenorphine. 2016, the first ever FDA-approved buprenorphine implant for opioid dependence, this Buprenorphine, was approved. And I don't know if any of you have had any experiences with that. I did not have a patient. I had a patient that was considering it, but I never had a patient that actually used the implant. So I don't know if anyone else has experienced that. In 2017, the FDA approves the first once-a-month buprenorphine injection. And again, there was some cost-prohibitive components to this, but it allowed for individuals to have a monthly injection, and it reduced the need for daily dosing and daily visits, or having a prescribed daily regimen for taking the medication orally. Just wanted to also look at just some myths and facts about buprenorphine treatment. So we know buprenorphine is an opioid medication. It's often given in this oral or sublingual or sublingual, in other words, under the tongue. There's two saliva glands there that where the medication is dissolved, and it's used to treat. Buprenorphine is used to treat opioid disorders. Other forms of buprenorphine are used to treat moderate to severe pain, and buprenorphine in the oral form is not used as a pain medication, and it's considered a narcotic. It's in the narcotic class of analgesics. So that's just and then so let's look at some of the myths that are sort of surrounding or constantly seem to be swirling around this notion or idea of using buprenorphine. Buprenorphine myth 1: patients are still addicted. Well, the fact is that a substance use disorder is is pathologic use of a substance and may or may not include a physical dependence. So this physical dependence on a medication for treatment, for the treatment of a medical problem, does not mean the person is engaging in pathological use. So if I am simply using that buprenorphine to treat my brain disorder, so that I can engage in treatment with a better ability and progress through my early stages of treatment planning, then there is not an active addiction, but I'm simply using this as a replacement therapy and using this to help improve the quality of my early recovery. Buprenorphine is simply a substitute for heroin or other opioids. Looks like I have the response to that on the next slide. So buprenorphine is simply a substitute for heroin or other opioids. This is another myth. It's one of those reveal slides. I didn't even know I had that in there. So the fact, buprenorphine is a replacement medication. It's not simply a substitute. Buprenorphine is legally prescribed medication, not illegally obtained. Although, it certainly can be diverted, but it's difficult to abuse because there is a ceiling associated with that, and it is not something that is easily abused. You're not going to get the high from it as you would other forms of opioids. Buprenorphine is a medication taken I can never say this. It's taken orally or under the tongue. It's sublingually. I don't know if I'm saying that right. Sublingually, but it's under the tongue, and it's a very safe route of administration. So you're not injecting this. It's very safe. You're not inhaling it. It's just taken orally, and it's a very safe means to get the drug into the system to serve as as an antagonist or as an agonist. Buprenorphine allows the person to function normally. And again, this comes back to this idea where we're treating the brain disorder first to allow the patient to engage successfully or more successfully in their early recovery continuum of their treatment and early recovery expectations. So engaging in pro-social, pro-recovery activities early on is much more likely if the patient is not actively in withdrawal and suffering from many of the physiological and psychological withdrawal effects. So myth number 3, providing medication alone is sufficient treatment for opioid addiction. Well, again, this myth, I think, would be countered by a couple of points. Buprenorphine is an important treatment option. However, the complete treatment package should include other elements. So it should involve some talk therapy, some group therapy, community support, and engagement in other pro-social and pro-recovery activities. It's not a standalone treatment, but rather treating a specific component of the opioid use disorder to better allow for that patient to engage in other parts of their early recovery. And also in conjunction with this, part of this idea is that combining pharmacological intervention with counseling and other ancillary services may increase the likelihood of success. So it fits with that earlier statement. Using the medicated assisted treatment component, the pharmacological component in this pharmacological therapy coupled with other components, counseling, group therapy, case management, other pieces to this, maybe mental health services, employment services, other components to this. So very important to not treat it just as a standalone treatment for opioid use disorders. Myth number 4, patients are still getting high. And again, we're using buprenorphine here as an example for these myths, some of these myths. Well, the fact is that when taken orally, buprenorphine is slower acting and does not provide the same rush as heroin. So it's absorbed differently, and it really is acting again as this agonist to sort of trick those receptors into thinking that the drug is present, and thus preventing the person from having urges, cravings, and going into withdrawal. And as I mentioned earlier, buprenorphine has a ceiling effect, resulting in lowered experience of the euphoria felt at higher doses. So, the more you dose with buprenorphine doesn't mean the more effects you get. It has a ceiling where it stops producing those effects at a certain dose. I hope that makes sense. But that's myth number 4, that patients are getting high somehow. And it's more about creating the equilibrium neurochemically and allowing the patient to proceed through early stages of their treatment and recovery. And really, we see this playing out in a longer version as they engage in their intermediate and long-term or post-primary care settings where they're doing continuing care and continuing to engage in the recovery community. Let's see. I wonder why that slide is. There we go. I think I had a double slide in there. Yep. Okay. So the advantages of buprenorphine in the treatment of opioid addiction. I would say the treatment of opioid use disorders. I always want to try and avoid that term addiction if I can. It has a lot of negative connotations, so I apologize. So the advantages of using buprenorphine in the treatment of opioid use disorders. Here are some of those advantages. The patient can participate fully in treatment activities and other activities of daily living. They have a limited potential for overdose. Now, that is not to say that they are immune, but they certainly reduce the chances of overdosing significantly. There is minimal subjective effects, so there's not a lot of sedation or immediate sort of obvious effects that you would see if they were taking the narcotic itself. It's available for use in an office setting, so it can be done through an outpatient setting, and there's a lower level of this physiological dependence. So some other advantages of using buprenorphine and naloxone, which the naloxone, again, is that antagonist that doesn't allow the patient to get the euphoric or high effects. So it acts as a block for that. It blocks the receptors from picking that up. It discourages the use of intravenous administration. It can prevent overdose deaths. And let's see, I thought I had a couple more there. Nope, I guess those are the 2. So discourages the IV use and can prevent overdose deaths. So using buprenorphine in combination with naloxone has those 2 primary advantages. I think we've looked at quite a few components to this topic, and I know we didn't have a chance to go all the way back to the beginning, but I wanted to make sure that we backtracked a little bit so that we had a chance to talk a little bit about the co-occurring disorders. Medicated assisted treatment certainly is something that if your agency is supporting this and you have administration that's supporting this, leadership that's supporting this in your agency, it certainly is something to consider and to be a proponent of. But it's certainly not a good fit for all clinics. But again, we looked at, in the just two-part series, we looked at evidence-based or best practice or promising practice. We looked at the therapeutic relationship and the treatment alliance. And I can't tell you how important it is to remember that the more you involve your patient in the treatment planning and the more you involve them in the decisions about their treatment, the more meaning, purpose, and importance they will attach to their treatment experience. Someone once said to me, and I think this was a quote from somebody, maybe Maya Angelou, but it really fits with this idea regarding the therapeutic relationship, and that is that a patient often will not remember what you said or did while you worked with them, but they're going to remember how they felt when they were with you. So one of the things that helped me in my early practice and stayed with me throughout my practice was to try and create a positive, supportive, unconditional positive regard for the patients that I worked with, even if they were struggling, even if their views and values were different than mine. They might remember how they felt and make it more likely for them to come back into a treatment setting if necessary. Patients will remember how they felt when they were with you, not what you said or what the treatment goals were. So something to keep in mind about that therapeutic relationship and involving the patient as much as you can as you collaborate with them. We talked about best practices. We talked about co-occurring disorders in review, and then we reviewed some of the pharmacological treatment options, especially pertaining to medicated assisted treatment and opioid use disorders. So that really concludes the broadcast for today. I want to leave you with that idea as you continue, those of you that are working directly with patients, to continually ask yourself, what are those underlying issues? That's really what your goal should be in working with patients, is to find out what's driving that substance use. I would often say to a patient, tell me what you like about alcohol. Tell me what you like about using marijuana. And this really allowed them to tell me what purpose it was serving. I didn't condone their use and certainly didn't demonize it, but trying to understand why they maybe started using in the first place opened the door for me to explore with them, if they were ready, to explore with them some of those underlying issues or conditions that may be driving their substance use. So something to keep in mind as you continue to work with patients and continue to maybe support and train colleagues around you. I did include couple of different reference sheets that would be available in this PowerPoint recorded version, and I'm certainly happy to share with you the PDF version of this PowerPoint if you would like it for future references. But I wanted to then just open the floor for some questions. I haven't been monitoring the chat box probably as well as I should have been, but just wanted to open the floor to some questions. Thank you, everybody, for attending, and I'll turn the floor back over to Ella and the group if we have questions.
Thanks, Steve, for that presentation. I think it's really important that you ended on that note where it's so important to let the clients know that you're not a closed door, you're not, stigmas aren't a treatment barrier in that case, and so it's really important to kind of have an open mind and treat them like an equal, because that's usually not what they get in their day-to-day life. But we had some questions in the Q&A. Someone asked, is Buprenorphine the choice for pregnancy?
You know, that's a good question. I know that there are proponents for the use of and consider the use of medicated assistance or medicated assisted treatment like buprenorphine during pregnancy, but then there are also individuals and research in the medical field that would be contrary to that. So I'm going to refrain from giving you a definitive answer on that. I think consulting with your obstetrician and consulting with your pediatrician or your family doc or your local medical provider would really probably be the best route to go. And I wouldn't make a recommendation one way or the other. We have to think about priorities, and we have to think about the safety of the mother first. Certainly the child is equally important, but the mother's safety and well-being is paramount. So I would say consult with your local OB or your local family practitioner to address that issue. But it's a great question.
And we had another question asking, MAT clients report feeling stigmatized in the 12-step community. I hear this is pretty common. In my area, there are few alternatives to the 12-step fellowships. How do we address this when referring clients to support groups?
Well, that's such a great question and a comment. I think as a person of long-term recovery myself, it wasn't so long ago, early in my recovery, if I went to, let's say, an AA meeting, an Alcoholics Anonymous meeting, there were certain meetings, and I would introduce myself as a recovering drug addict and alcoholic, and I would be approached after the meeting by another member saying, this really isn't a meeting for drug addicts, it's only for alcoholics. And that was many years ago. I think there is a shift and a change happening in the fellowship and recovery community, where there's more openness to and more acceptance of individuals utilizing medications like this to address their long-term opioid use disorders. The stigma is alive and well. And will remain probably for many of us that are in recovery from substance use disorders or mental health disorders. I would encourage you to contact your local group representative or AA area district representative and talk about the importance of there being a singleness of purpose and only one requirement for membership. I think there's been a bad rap too. In the past, we used to call certain individuals using marijuana maintenance or using one drug or another because that really wasn't a problem for them. That's different. Using a medication like buprenorphine or methadone is really equivalent to, in my opinion, a diabetic, taking insulin so that they can live a better quality life. And if we start excluding people from attending meetings, then we need to revisit the principles and traditions connected to the 12-step community, because it's nowhere does it say someone is excluded. And in fact, the decisions were made to allow individuals to attend meetings, even if they were dually addicted. And they reference that in the basic text. So it's unfortunate. And I would encourage your patients to think outside the box, There are a lot of different pathways to recovery. So maybe finding Wellbriety or rational recovery or some other format. But if they don't have access to that, and really all they have is one or two AA meetings, it can be addressed in a group conscience or in a business meeting too, through the GSR or the district representative. But thanks, that's a great comment, and it's unfortunate, but it's true, what you said.
We had another question from Lynn. She asked, is it true that there's a vaccine for cocaine that's on the verge of being approved in the USA?
Boy, if there is, I don't know what that would be, other than to maybe, I don't know what the vaccine would be. I'm not aware of that. That's an interesting. Have to tell me more about that, or maybe if you have an article or something you'd like to send my way, I'd love to read about that. I know for a while they were working on a vaccine related to opioid use disorders. I have an article on that I read last year about developing a vaccine to address opioid use disorders. So maybe it's something similar. Oh yeah, it looks like Lynn is referencing that. Yeah, I would love to know more about that. I'm always a little apprehensive about vaccines being sort of the catch-all, or the sort of silver bullet, if you will, the magic bullet, I should say, to take care of an issue that's been an ongoing component of our society for hundreds of years. So. That's interesting. Yeah, I would. If somebody wants to send me that article or that reference, I would love to see that.
We had another question. Is there any evidence that people who become addicted to opioids after being treated with them due to an injury may become addicted more to deal with the traumatic effects of the injury itself?
Yeah, that's There, as far as chronic pain issues go, is that what we're referring to?
It sounds like it, because a lot of times doctors refer people to opioids, and then those patients get addicted to those. So they're saying, does the injury make them more susceptible to opioid addiction versus? It sounds like, yeah, if that's like another susceptible factor, or.
Well, it certainly there are some pieces there that are pieces. There's some components to your question that do make it difficult for us to say that if a person is experiencing chronic pain and they're prescribed a medication that's opioid based, if they're more susceptible. I think we have to look at a lot of different factors. I think what you're getting at is maybe asking whether or not that's something that would make you be more at risk by taking a pain medication. And I don't think that it's fair to say that all pain medications are necessarily put the person at risk for developing a dependency issue. Remember, you can become physically or physiologically dependent without being psychologically dependent or going through that pathological behavior of addiction. So I think it's something to be very careful of. There's a really heart-wrenching documentary about a young man who goes in for ingrown toenail surgery when he's about 17, and they prescribe him Percocet or something as a pain management, and it opened the door for him, and something, he described it in his journal as something clicking in his brain, and it was like a key going into a lock, and it opened him up and to this idea that the opioids were the answer, and he went on to die of an overdose at a very early age. But that's where it started, was just a simple surgery. So I don't know if that addresses your question or not, whether or not that's what you were getting at. But
Ben Ryan asked, what's OAT?
yeah, OAT. So Ryan, that's a good question. I believe it stands for opioid antagonist therapy. So it would be taking a medication that would block the effects of the opioid. I believe that's what that acronym is. There's so many of them floating around out there, but yeah, I think it stands for opioid antagonist therapy. Other questions or thoughts? Ella, do we have anything else?
We have one question. Do you receive funding from the makers of buprenorphine?
No. No, we are funded through SAMHSA. It's a federal grant, but I have no connection to buprenorphine. I just simply use that as an example.
So if you look at the example on Classroom, you have...
Yeah, it sounds like they just wanted a clarification.
Yes, I have no affiliation with anyone producing or promoting.
If you want to do more than that, Sean, you
just
can.
use it as an example.
I'm just looking for kind of one per. Okay?
I'm hearing a voice too. Is there another?
I have several.
Oh, you have
housemates.
You're multitasking over there, Ella. I wanted to make sure I wasn't hearing something on my monitor.
If there's any more questions, you guys, we would love to see them. So feel free to post in the Q&A or in the webinar chat box.
Yeah, that's a good point. Ben had said it shouldn't matter what addiction, but what addiction between drug or alcohol. I think he meant addiction. What addiction? Because they're all drugs. Yeah, just asking because AA meetings, I would think that that would be something most would be open to it to help with addiction. And I agree. And I think that shift is changing. I do think that there's a shift where there's more acceptance of individuals who are in recovery from multiple substances and who are also perhaps relying on pharmaceutical intervention to help maintain quality of their recovery. So I think there's a shift happening, and I think you would see much more acceptability in some urban areas. And I know here in Iowa City, the fellowship is very receptive to and accepting of individuals who are on medicated assisted treatment or who are also reporting as recovering addicts and alcoholics. So the shift is happening, and I think it's changing. So yes, good. That's the first time we've used the Q&A box there. It's a new feature on the webinar. So Ben, thanks for being the first Q&A box person for me. Appreciate that.
We had an interesting comment from Clem. They said, sadly, I work for an agency that's providing MAT, buprenorphine, methadone, Suboxone, etc. as the solution versus having it coupled with treatment or counseling, saying it will push away potential clients if they have to have counseling or other treatment. Do find that this happens a lot in communities that do offer medication-assisted therapy?
Well, that's a great point, Clem, and I think there's a mixed sort of bag on this because you know, I wouldn't want to create barriers for patients to access the medication, saying, you know, I'll only give you this if you do A, B, and C. But I think there has to be a balance between some agreement to engage in additional services other than just the medication. Even something as simple as a urine screen to make sure that the patient is not using other substances that may interfere or impact their ability to recover and avoid other consequences. So it's really, I think it's a difficult question to address. I would question any facility that was really using medications as a standalone. The idea is, you know, if I'm a physician, this is maybe an example that's maybe a bit of a stretch, but think of it this way. If I'm a physician and I am under some sort of pressure in my practice to see as many patients as I can in a given day, and I can see 50 patients in a day, gentleman comes in, patient number 13 says, my knee hurts. It's very easy for me to say, let me just give you some medication for that and write the script, and he's on his way. I can see the next patient immediately, and I don't have to explore with that patient alternative methods, maybe non-narcotic interventions, other options to look at why his knee is hurting. So I think that's part of this mindset is how can we treat as many patients as we can and meet sort of the goal of serving X number of patients. The other part of me says I would rather have a patient engaged in medicated assisted treatment or medicated assisted therapy and not have those barriers or obstacles in the way, so that they at least know that they're welcome and they can get the medication to give them an opportunity to recover. But I think you're running a real risk by just giving medications with no follow-up. Once the patient's gone through the induction and starts the medication regimen, I think it's irresponsible not to have some follow-up and to do some monitoring and tracking to assure that the patient is safe and has opportunities to engage in pro-social and pro-recovery activities. So yeah, that's unfortunate, Clem. I would say, addressing that with leadership or the administration of the agency or the stakeholders or the board might be a nice way to bring that into light. But that's a great point, and I know that's happening. I know there were studies done with methadone clinics where they did research on having the patient come in and just take their dose of methadone and go about their business versus having them take their methadone and then also stick around for a support group. And there really was no significant difference in outcomes. So there's that piece of it too. I think it's more best practice, best practice and responsible practice as to whether or not you offer additional services and monitor the patients that are being prescribed medications to address their opioid use disorders. It's a great comment, though, Clem. I appreciate your comments.
John asked, do you have any examples of long-term recovery with clients who use buprenorphine, then go on to quit using the drug, and then remain clean with no opioid relapse?
I don't have a case in particular. I know the goal is to reduce the dosage and eventually have that patient off the medication completely. And the notion or thought would be that if you've done some work with that patient to sort of insulate them or provide some other protective factors related to their recovery, that the medication is one piece of, but not the only component to why they're staying clean and sober. So I think it's a good point. I don't have a case in particular to share with you, but I do know that most prescribing physicians or agencies would tell you that the goal is to have the patient reduce their dosage down to where they can be discontinued, whether that's stretched out over months or years. I do know that I attended a conference, it's been a couple years now, but the keynote speaker was a person of long-term recovery, and he had been taking medicated assisted treatment for a number of years. I think he had been on a very low dose, and it had been 8 years since he started his journey in recovery. So, there are a lot of pathways to recover, and this one worked for him, and he seemed to be really living a good quality of life, and was trying to help others to recover as well. So, yeah, it's I know there's some good stories out there. It's finding the right one, but I appreciate your question. I really do. Yeah, Lynn makes a good comment too about their prescribing of opioid medications or the medicated assisted treatment medications. Yeah, and it's good to have a nurse practitioner or an MD overseeing that, so that there's some oversight and some regulation. And I know a lot of, there's quite a bit of regulation that's come into light in the last few years, and to make sure that there are protocols being followed for the prescribing individuals. And there's some liability and some responsibility ethically on the part of the prescribing practitioner as well as the agency. So, yeah, that's good, Lynn. That's good. That's good news. Well, again, I do want to thank everyone, and really appreciate your time and attention, and it's great to see some familiar faces, and really do appreciate everyone's comments, and I certainly wish I could see some of your faces, but I understand that's just the world we live in, and if we were in a room together training live, then we would have a little more interaction. But thanks again, everyone. I appreciate it. And if there's no further questions, I think we'll conclude today's broadcast. Ella, unless you have any questions that I missed, I think we'll wrap things up.
Yeah, I think we covered everything. And if you had a question that we missed, we will make sure to go through the chat and maybe answer that next time. Please fill out the quick survey we sent out if you have some time. We really appreciate your feedback, and yeah, it's just a quick survey, and it really helps our center.
Yeah. So we'll do another ESAS broadcast next month. So look for that probably first or second week of October. And if I don't see you then, we'll have someone else here. But it's been a real pleasure spending some time with you this afternoon. And also one more plug, if you can. In about a half an hour, I have a wonderful guest on our native storytelling hour that we're going to broadcast here in about 30 minutes. It'll be at 2 o'clock Central. So if you have a chance, come and join us for an hour of storytelling from a great storyteller out east, a native storyteller. So I'll put that little plug in, and that's my piece for the day. So thank you, and Everybody stay safe and healthy.
Thank you, everyone. Have an awesome day.